Chan Cheah. I'm a consultant haematologist at Sir Charles Gairdner and Hollywood Private Hospitals. So the question is, what is mantle cell lymphoma? Mantle cell lymphoma is a rare subtype of lymphoma, probably only around 3 to 4% of all lymphoma diagnoses. It's an aggressive lymphoma, which means that it grows pretty quickly. It tends to affect slightly older patients than other types of lymphoma, with the median age of diagnosis of around 70. And it seems to affect men more frequently than it does women, with a ratio of about 3 men for every 1 woman who's diagnosed. The characteristics of mantle cell lymphoma are that it's rapidly growing, like diffuse large B-cell lymphoma, but unfortunately it tends to have a frequent pattern toward relapse, even very late relapse, much like follicular lymphoma. So in some ways it's got the aggressive behaviour of a large cell, but the tendency to relapse of a follicular lymphoma. The frontline treatment of mantle cell lymphoma depends on a few things. Probably the largest thing that we think about is whether someone is young enough and strong enough to have a procedure called an autologous stem cell transplant or not. The cutoff for this is roughly 70 years of age. It's not always strictly age-based, but it tends to be around about that point. And it's about your fitness and your other health problems as well. Generally speaking, patients who are under 70 and who don't have other major health problems, we would consider to be eligible for an autologous transplant. And the treatment of those patients is a chemotherapy regimen with rituximab. There are quite a few different chemotherapy regimens which are used for mantle cell lymphoma. The most common ones in Australia would be one called the Nordic protocol, the Nordic MCL2 protocol, which is a combination of CHOP at higher doses with a drug called cytarabine, which is an infusion with rituximab. The other regimen which is commonly used is alternating CHOP and DAP, which is a platinum-based chemotherapy regimen with cytarabine. So those are probably the 2 commonest ones. There is a chemotherapy regimen called hyper-CVAD, which also contains some cytarabine, and so they would, those would probably be the 3 most common treatments used. There are actually there is no real consensus about what the best one out of all of those is, but they all appear to be pretty active. In the second setting, which is patients who are not eligible to have an autologous transplant, and just to refresh your memory, this is patients who are either over 70 years of age or who have other health problems that mean that it's too risky to do the stem cell transplant. Probably in Australia at the moment, the most common chemotherapy program used is bendamustine with rituximab, and other treatments used in this setting are R-CHOP with rituximab maintenance, but some variant of bendamustine is probably the most common treatment there. The question is, what are the most common presenting symptoms in patients with mantle cell lymphoma? So much like other subtypes of lymphoma, patients with mantle cell lymphoma frequently present with enlarged lymph glands, which they may notice themselves. They can present, if they have quite a lot of lymphoma present at the time that they're diagnosed, with fevers, drenching sweats and weight loss. In contrast to other subtypes of lymphoma, patients with mantle cell lymphoma have a higher, they're more likely to have involvement of the gut, so they may have, for instance, diarrhea or constipation, stomach pain, or bleeding from the bowel, or black-coloured bowel motions. It's not overly common, but we do sometimes have patients with mantle cell lymphoma referred to us on the basis of an abnormal finding on a colonoscopy, for instance. It wouldn't be the most common way of being diagnosed, but it certainly can happen that way. Patients with mantle cell lymphoma also are quite likely to have a small amount of circulating lymphoma cells. So when you do a full blood count, there's a raised lymphocyte count, and when you look at patients' blood under the microscope, you can actually see the lymphoma cells floating around. And that's something that is less common with other subtypes of lymphoma. So the question is, what percentage of patients go into remission after frontline treatment? The answer is most, around about, depending on the treatment which is used for younger, fitter patients who have the intensive chemotherapy programs. 90 to 95% of patients go into remission following a cytarabine-based chemotherapy induction. For patients who were treated with lower intensity regimens such as bendamustine, the likelihood is slightly lower, but it's still very high. But the issue with mantle cell lymphoma is not achieving initial remission, it's actually the relapse and the management of relapse. So the question is, do all patients with mantle cell lymphoma need treatment at the time they're diagnosed, or is there a subset of patients who don't? The majority of patients with mantle cell lymphoma, unlike follicular lymphoma, do require therapy at the time that they're diagnosed because it's usually an aggressive and fast-growing lymphoma. However, we know that there are around about 10 to 15% of patients with mantle cell lymphoma who have what we call indolent mantle cell lymphoma or slow-growing mantle cell lymphoma. So how do we define these patients? They tend to have they don't have very large lymph nodes, so they're not what we call bulky, nothing more than sort of 5 centimetres in size, or certainly more than 3 centimetres in size. They don't have any of the symptoms such as fever, sweats or weight loss. Often when you take the biopsy, in mantle cell lymphoma there's a marker called Ki-67 or proliferation index, which is quite prognostic, and the patients with indolent mantle cell lymphoma almost always will have a low index of under 10%, and these features are so finally, patients with indolent mantle cell lymphoma often have what we call a non-nodal presentation, or they have predominantly leukemic disease with lymphoma cells circulating in the blood and an enlarged spleen. So if you have all of these things, then we know that you can actually be safely observed, and I think the longest the longest that I've observed a patient with this situation is about 14 years. So the question is, what's the prognosis of patients with mantle cell lymphoma? The prognosis varies depending on a number of factors, much like other subtypes of lymphoma. So firstly, younger and fitter patients have a better prognosis because we're able to deliver more intensive chemotherapy programs and a stem cell transplant. The way that we estimate prognosis in mantle cell lymphoma is using a prognostic scoring system which is specific to mantle cell lymphoma. It's called the MIPI. It takes into account, you can Google it and see what the features are online, but essentially it's measuring two things, as with other types of lymphoma, what the age and fitness of the patient is and how much lymphoma they have. A more up-to-date version of the MIPI incorporates information about their biopsy as well, and in particular the presence of how quickly their lymphoma is growing, as defined by a marker called Ki-67 or the proliferation index. So using all of that information, you can plug it all into a scoring system and give someone an estimate of what their prognosis is, from very favourable and intermediate to less favourable.